So good morning, everybody. I'm Dr. Kiran Kumar K, Professor of Psychiatry at Vydehi Institute of Medical Sciences, Bangalore. I'm also the coordinator for the Sunday Special program, which we started about an year and a half back, somewhere in March of 2021, as a combined effort of IPS Faculty Training Task Force, IPS UG Education Subcommittee, and IPS PG Education Subcommittee. We've been successfully running this program. We always felt there was a specific need for a platform for psychiatry teachers across the country. And it was a felt need that we also explored through various surveys that we had conducted as a part of Minds team. One thing that we have been ensuring is there should not be much of a pharma participation, and it should be an independent program that we will be able to use it across platform without any pharma involvement. And we have been successful in doing that over the past year. So today we have been having an important activity called as an Entrustable professional activity. Though it has been in vogue for some time, probably with the advancement of Cbme curriculum for both UGs and a little bit of emphasis on PGs, this is quite an unique construct and a concept for all of us as medical educators. To take on through this session, I would like to welcome the moderator for the day, Dr. Ajay Kumar, Assistant Professor from AIIMS Raipur. I welcome you, Dr. Ajay. I hand over the session for you to kindly moderate and introduce the speaker and the program. Thank you.
Thank you, sir. So it is my privilege to be, becoming a moderator on on this precious program. So today we have speakers from Pune and Andhra Pradesh, and also we have students. So as we know that our first speaker is Dr. Kaushik Chatterjee, and he is a professor and head of the Department of Psychiatry, AFMC Pune. And he has done his research on this particular activity, and that becomes the theme of this today's program. So we will be inviting him first, and followed by we have other speakers. So I will invite Dr. Kaushik for first speakers, and then later we will move to the other speaker, that is Dr. Sanchez Striker, and he is associate professor in Department of Psychiatry, AIIMS Bibigiri. Although it's a new institution and it's just started its undergraduations, so he will be focusing more on the undergraduates part of this theme, and then we have students, and both the speakers name incidentally Ankith. So we have Dr. Ankith Reddy from he's a MBBS student, and he's speaking and representing AIIMS Bibigiri. And we have Dr. Ankit Dangi. He's a senior resident, and he will be representing the Department of Psychiatry, AFMC Pune. So let's start with our first speaker, Dr. Kaushik Chatterjee. Welcome you, sir.
Thank you very much. Thank you. It is a privilege and an honor to get to present both our thoughts and what our work in the department has been over the last couple of years in this connection with EPAs. What I would like to urge everyone to realize that it is not one person, me, it is the entire team at AFMC and Command Hospital Pune, which has worked towards this, and I just get the opportunity to present the work that everybody else has done. So I'll just share my screen. Right. Are you getting to see my full screen?
Yes, sir, it's visible.
Good morning, everybody. I'm glad all of us have been able to take time off on a Sunday morning for this. Greetings from Armed Forces Medical College. I shall talk to you a little bit about the background, how we are here talking to you about EPAs today, a little bit on the concept, how we had our first iteration of EPAs and how it was full of flaws, the challenges we are facing with implementation now and the way forward. So, firstly, a caveat. Sorry, what have I done? Excuse me. I will just go back to. Are you seeing all my slides or only one?
It's all your slides are visible,
All
sir.
yours.
You can just go
Okay.
back to the screens thing, I think.
Yeah,
Yeah,
is this
yeah,
now on
yeah.
slide?
The
Yeah,
first slide, yes.
I'm sorry.
Yeah.
Okay, first thing before we start, I want everybody to have this very clear that EPAs or Entrustable Professional Activities are not, I repeat, not a substitute for the curriculum. EPAs merely help us align the practical or the clinical training to what a specialist, in our case a psychiatrist, ought to be able to perform. Now, all this came about when there was this query raised about medical education around the world and particularly in India that did one become a surgeon merely by passing exams, or should a surgeon actually be able to cut and put things back together? So the timeline of our story is something like this. All of us were party to the lockdown on 25th March 2020. We were suddenly jobless or doing new jobs or different jobs dealing with the pandemic when the entire department on both the medical college and the hospital said, hey, we can't stop what we are doing. Let's use what we have. And 2 weeks later, we were having our first virtual journal club. And from then on, it remained virtual for a while before we went back to real life. A month or so down the line, all of us in the faculty had these worries. Were the residents actually learning? Can we teach psychiatry on a screen? This bothered us no end, and we started exploring. We had already some experience with the undergraduate Cbme. Then we started exploring what should be the postgraduate competency-based medical education for a degree in psychiatry through a 3-year residency program. We delved, we dug, we found out, we did our own things. And from June to October, 4 months, that is what we did a lot of the time when we weren't doing extra duties in COVID wards. And we learned that assessment has to be a big part of it. We realized that we were not assessing very much in the workplace. So we delved into workplace-based assessment. And what we did regarding EPAs, I shall tell you down the line. So, as all of us are aware, there has been a shift in postgraduate medical education. We all know that we have time-based rotations in medicine, neurology, wards, outdoor, this, that, and the other. And that is measured in certain ways. But we have moved from there to outcomes, both educational outcomes that have people actually learn what we want them to learn and are they able to practice it in the workplace. So who are our stakeholders? Of course, our residents, our learners are our first stakeholders. The faculty who have to reorient themselves and acquire skills and attitudes for this new paradigm of teaching and learning are the next. The public, who are the eventual users of what we produce, are another set of stakeholders. Actually, I think they are the major or the primary stakeholders. They are the ones who were being underserved earlier through an examination-based system. The fourth set of stakeholders are the educators. Some of us have gone and done degrees in medical education. Alas, not me. Uh, they came up with a very detailed CBME program, which we tried to implement, the one which was on the erstwhile MCI and now the NMC website. It has lots of competencies and milestones and is really, really difficult to operationalize. What do we want to operationalize? We want to see that we have a holistic system of learning which can be done in the workplace and which can be assessed. Because as we all know, assessment drives learning. So what is an EPA? It is a single or a bundled unit of professional practice, like the ability to conduct a diagnostic evaluation. So what are the requirements of an entrustable professional activity? That activity should be executable within a given time frame. You can't take all day when you have 80 patients waiting in your OPD. It should be observable and of course it should be measurable. Otherwise, what are we doing? We have to integrate multiple competencies in knowledge, skill, and attitude domains into one well-defined professional or clinical activity. Taken together, this is a philosophical part. All the EPAs of a given specialty define that specialty's core identity. So we can't be, what should I say, casual when we are defining the EPAs. Why do we need EPAs after all? It's because we need to answer these questions. Are clinical competencies actually being gained from this residency program, or are we producing theory masters? Then, can we really assess things in a busy workplace? Can we align assessment to both the curriculum which the NMC wants us to implement or the medical university wants us to implement and to the workflow of a busy clinical learning environment? Can we align our EPS to both these things? Another thing I want you to dwell on, which is again partly philosophical in nature, that trust is a central concept in medicine. We have to be able to generate that trust for safe and effective healthcare, and that becomes an important concept in teaching and learning. So, the goal of residency is that residents have to be entrusted to do the desired professional activities independently. We don't want helicopters hovering over them. And by the way, this is done implicitly all the time. From the time our residents join in the first year, when we joined, to the third year, we progressively become more and more independent because our faculty lets us be so. EPAs merely operationalize this. They give us an explicit framework to do this in. They define or delineate the units of work. As we go along, you'll realize is the toughest part, writing out the EPAs. We have struggled endlessly over it. And the aim is to make these competencies and milestones of the EPA meaningful for the eventual health practice. They cannot be something which are peripheral or historic. They have to be current and future oriented. So how do we assess? The aim was to develop a curriculum which could be implemented in the workplace, which was meaningful for what a psychiatrist should be able to do in the next not just 1 year but 30 or more. And there thus is required continuous assessment throughout the program. Now, all of us already have some manner of continuous assessment, whether we like it or not. Like, for example, in my medical college, all case presentations, seminars, journal clubs are assessed by one faculty member and scored. Now, these scores are entered in the logbooks, and as we went along, we realized how our present logbooks fall miserably short of what we want to capture if we are looking at EPAs. The logbooks measure various things like journal clubs, seminars, case presentations, emergencies attended, and so on and so forth. Now, this gets mapped to the 3 years of internal assessment in our medical college. So, for any resident, you have a record of all the journals presented, cases, seminars, clinical practice guidelines, and so on and so forth. Now, do we record formative assessment? Yes, we do. From time to time, every year, we are having that. And in the armed forces, so you can compare the performance between various residents. In the armed forces, we have something called a grading exam, which is 8 weeks before the MD exam. What we do there is we give 50% marks for internal assessment and 50% for the exam. And we help people prepare for the exam through open book exams, mock exams, and so on and so forth. There also you can see the performance of these 4 residents of that batch, how they performed relative to each other. So internal assessment is already taking place in different ways in different medical colleges. It is not something new. We just have to redefine or expand the scope of what we are doing. So we thought we understood something about workplace-based assessment, and we wrote this paper, which was published in March of 21. And I will tell you, now I know parts of it were quite wrong, because that time we didn't have hands-on practice as we have now. So we set about developing the EPAs. It involved the faculty, the senior residents, and also the finally a batch of junior residents gave inputs. We organized the EPAs initially by disease, then by task and location, the modalities and the complexities. That means the easier EPAs were more focused in the first year, the toughest ones in the final year. We then drew up this long list of EPAs, which was a mistake because we made it too long. And then we stratified it into vital, essential, and desirable. So translating into use, now there is ad hoc entrustment which happens in the OPD in the ward every day. So after, when I am the faculty member, after the resident has convinced me that they have presented 6 cases of this type, they can formulate a management plan, I give them a go, no go kind of situation. See, okay, you're not yet ready to do it independently on your own, or yes, you are. Now go ahead and prosper. That kind of situation is made by individual supervisors for individual trainees all the time in all medical colleges. There is immediate permission to act in specific limited contexts, like you attend this call and tell me over the phone and decide whether I am to come and attend or not. Something like that. What we are looking at is a formalization of this into a summative entrustment by way of a systematic modality of observation, a lasting permission to act under a specified level of observation. Would it be the psychiatrist in the same room, in the same OPD complex, or over the phone, or not at all? Are we preparing for a license? Is this going to be first cleared by a clinical competency committee? We are not there yet. It is a long way to go. So what are our assessment methods? Direct observation, of course, in the ward and the OPD. Review of documentation. Does the case sheet contain everything that is important? Multi-source feedback from the peers, from the patient, various things. And in training examination, present the case to me. Or what will you do? How will you prepare for ECT? And so on and so forth. So the aim of all this is transparency, clarity, and ease of use. What is the context of implementation? Certain EPAs are better learned during certain specific rotations or in certain specific clinical learning environments. For example, during the inpatient rotation, it is these are the EPAs that are probably relevant, like how to conduct a diagnostic evaluation, how to manage the patient longitudinally and see the response to specific medications. On the first day, you have given injectables, the person has responded. You moved on to oral, the person did not meet your rate of desired response, you increase the dose, and so on and so forth. And also to manage the transition, how we hand over to the psychologist, to the social worker in our ward, or how we, after discharge, how do we ensure follow up. So we were doing this and we thought we had learned a lot about EPAs. You know, हमने सोचा कि हम शेर बन गए, so we wrote an article and we published. Now we know when we went to implement it what we were already doing a little bit of implementation, but now we know there is much more to it, and I will tell you about that. So I'd taken you up to the workplace-based assessments in November 2020. From January to June of last year, 6 months, we slogged on the EPAs, and at the end of it, we had them ready, and we thought the new incoming batch will be our guinea pigs, and we will launch the EPAs on those poor unsuspecting creatures. Alas, the second wave happened. This new batch joined only in February of this year, and immediately they had their induction training, and then we have basic research course, etc. So they were not available to us for 6 weeks thereafter. During that time, we did not sit easy. When we were having our seminars, journal clubs, case presentation, at the end of any typical seminar or journal club, we would have a few minutes spent on how does this contribute to being a psychiatrist. So some amount of discussion or narrative about EPAs was already taking place in the minds of both the faculty and the residents. What did we learn? That we have to have continuous assessment through various tools. We have to formalize direct observation by faculty members, multi-source feedback from various people, and end of each rotation, more comprehensive feedback. Now, I know we need to build portfolios and audit the practice. We have not gotten there yet. Now, what are the assessment strategies? What do they tell us? What have we learned? One is we are too easy to rely on quantitative data because it gives us a trend whether a person is learning or not, but there is subjectivity in that also. We have learned that we need to have more narrative data because that gives both explanation to the resident and also guidance to the residents. What do I need to improve? Just a score is not enough. And eventually, when we set up a clinical competence committee, they will have to give more comprehensive feedback. And this narrative helps to determine the context of quantitative scores. One thing which we have learned very clearly is that we have to have multiple assessments of the same thing by multiple supervisors through multiple methods. That's the only way we can remove bias or minimize it to a certain extent. Now, many things which are so intuitive for us are not easy to assess, alas. I will show you something called PSCO and how mobile apps are coming in, but they are fragmented. We are really not up to there with assessment methods. Now, this is the psychopharmacotherapy structured clinical observation chart. Imagine a busy clinician being asked to score 27 things. It is not easy. We have to figure out how to simplify these things. Otherwise, it will remain an ivory tower, a desirable thing which will not get implemented in real life in the busy wards and OPDs that we handle. Ward में तो फिर भी हो जाता है. OPD is one place where we have to up our game, is what I have realized. I have also realized that this is very much an iterative process. It has to be user-centered. It has to be primarily focused on the resident. But at the same time, we have to make it easy for the supervisor and the faculty. We have to focus on feasibility and ease of use. Right from the beginning, we have to be sure that we are generating high quality data, otherwise it is useless. We have to have assessment tools built within the workflow in the clinical work environment, otherwise it's going to fail. Now here was a debate between paper versus application. My younger faculty is absolutely certain that e-portfolios are the way to go forward because they are location independent. You can enter them anywhere. There is an immediate record. There is no recall bias. But the hard copy also has certain advantages, like it's more thorough. You can look at it at the end of the day. You can reflect on it. And it gives systematic feedback to the resident. We have to invest in faculty development through performance dimensions. We have to train for consistency in behavioral terms, in frames of reference, in keeping aside time within the workflow to assess and monitor the data and manage it. Otherwise, we will have huge amounts of data which will be meaningless. So what is the future? We are very clear that we have to redraft what we have done. It is not good enough. And the next batch coming in will be our next set of guinea pigs who will endure with us the process of implementation. We need to develop either an e-logbook or a portfolio to make things easy and available on the spot. Eventually, we have to evaluate impact. That means, are these EPAs actually valid, reliable? Are they acceptable? That's the most part. See, it was resisted very strongly by some faculty members who said कि इसकी कोई ज़रूरत ही नहीं है. Do the EPAs contribute parallelly to academic improvement? And what is the cost in time and effort in implementing these EPAs? So to summarize, EPAs are an opportunity for learners and faculty to improve and align clinical performance to the requirements of the public and to practical expectations. Once again, the caveat, EPAs are complementary or in addition to the NMC framework of Cbme. And sadly, the implementation demands blood, sweat, toil, and tears. Thank you very much. I have finished.
Thank you, sir. It was a very enriched and very comprehensive presentation, and we have learned so much and from this presentation. And though there are lots of things like e-portfolio or e-logbook and the paper pen logbook, and some of the conversation and discussion we also doing in our IPS faculty task force and the other committees. Okay, so that's a different thing, and so it's a very interesting presentation. And now we shall move to the other presentation. We can take the questions and the queries in the last. And if anyone has doubt, any question, any particular query from the presenters, then they can put it under the inbox, and we will address in the last. So now our next speaker is Dr. Sanchez Striker, and let's see his experience. Dr. Sanchez Striker, please, you can start your presentation.
Let me share my slides.
Sure, sir.
Is my
Yes.
slides visible? Yeah.
Yes, sir. Visible. Sir.
Thank you. Thank you so much, Dr. Ajay. It was indeed a wonderful presentation, Dr. Kaushik. Compliments. At the outset, I would like to thank the organizers of this wonderful webinar series that's been happening for some time. And indeed a pleasure. But to be honest, I would rather disclose this and that, I'm not done, first-hand research on this, unlike Dr. Kaushik. And unfortunately, in my undergraduation, I hadn't opted for psychiatry. But as the destiny decides, and I'm now into undergraduate psychiatry teaching. So I will quickly take you what is the relevance of Entrustable professional activities and undergraduate psychiatry training. And initially when this topic was given to me, I had a rough idea of what this is and what NMC was trying to do with this particular topic. Now, if you can understand myself, in our I guess in the final year of post-graduation, our senior residents used to call us when the lot of follow-up cases had increased, and there are 60 follow-ups pending. They would call us and give us a bunch of files, that please take care of these follow-ups, and we would actually do the examination, and in most cases just say continue the same treatment. What I understand from that is that we were interested on one professional activity that do this task. So that is how I understand and relate what is Entrustable professional activity. And to understand more of how this is important to undergraduate psychiatry is what I try to gather and I'm trying to present. Say for example, a plastic surgery faculty colleague of mine tells me that his sister is not well after her recent divorce and wants her to be examined. And who do I think is the best to take the detailed history and do a mental status examination? Of course, myself, because that plastic surgeon has entrusted that activity on me. And for some reason, if say I'm not available, at least for some time, and just to take care that that client is there, and some activity happens. So I would rather want some of my junior colleagues to take a detailed history and do a mental space examination. So who will that be? My junior resident? Is that the 7th semester undergraduate student? My senior resident? Or the intern? Most likely, I would rather give that task to a senior resident. Definitely yes. Junior resident may be, may not be. Again, there are so many dynamics here. It depends on what level of training he or she is in, and what kind of how reciprocative is that particular resident. Intern, not likely. 7th semester undergraduate, definitely not. This will be how I would grade my trust in examining a client. Now, when I say a faculty colleague and not any case, so here comes the issue of trust. Now if it is a very close case of a relative of mine or a very close contact, and especially a doctor, I want that trust to be that trust is always on the higher level, that that I'll have to be very sure of what that person is going to be. So what is Entrustable professional activity? There are different definitions, but then there are certain aspects of it. That is, it is a unit of professional work. What's actually done during a clinician's day, this is what it is. So something we can do, but can be entrusted upon others, and that which can be observed and assessed too. So something that can be assigned, measured, or observed. That same thing that a supervisor could trust a learner to do independently unsupervised. And it should be a manner in which it should be a way to teach and assess learners too. So these are the aspects in which the definition of entrusted professional activity is. Now the question comes, have we trained our undergraduates to be entrusted yet? No, see, from my previous case scenario, no, we don't yet, we don't entrust our undergraduates to do detailed assessment. But the question is, when can they be entrusted? So this is entrusted professional activities in a definition from the Royal College, Canada. It says authentic tasks of a discipline. A supervisor can delegate a task to a resident. So it specifies a resident and observe their performance in the workplace. Over time, frequent observation of a trainee's performance of an entrusted professional activity will provide a comprehensive image of their competence and inform promotion decisions. So one outcome is promotion decisions. So it starts from the junior resident where he's transitioning into this discipline, understanding the foundations of the discipline. From then on, he progresses higher and becomes a senior resident, then a practicing physician. That is how the transition happens. So from foundations of discipline, he goes into the core of that discipline, and then he translates all this that he has learned, understood, observed to practice. So this is how the pyramid goes up. So there are 5 different types of entrusted professional activities that Royal College Canada has very clearly defined. One is assessing, diagnosing, and participating in the management of patients, performing psychiatric assessments, developing and implementing management plans for patients, performing risk assessments, performing critical appraisal, and presenting psychiatric literature. Like I've told you, Royal College Canada tells that this is only for residents. Now, can all these activities be implemented lower somewhere, before the transit into junior residency? So, for that matter, undergraduation. So what is APA? Like Dr. Kaushik told, it is a complement to competency, but rather I would say that different competencies lead to specific EPAs, which are professionally important. They have to be manageable for learners and meaningfully assessed by faculty, like I've already told. So there are different competencies, and some of these competencies could be clustered into one entrustable professional activity. Now, coming to the Cbme curriculum, our undergraduate curriculum, generally, in psychiatry, this is how it looks like, the competencies. So just for example, this is PS, that is psychiatry 10.2. So enumerate, elicit, describe, document clinical features. This is there for different psychiatric disorders. So column C is whether he knows, shows, and all that. D is very important here. It shows how. He has to elicit a particular thing. Then how is it done by bedside clinic? How is assessment? It is important for skill assessment. H column is the one which tells that whether that can be performed independently. If yes, please put Y. And I'll tell you that none of the competencies in psychiatry will require any task or competency to be performed independently in this particular curriculum. So there are in total 40 skills or competencies that are put in the category of show how. Totally they can be grouped into 10. Like I've told you, none of these competencies have to be done independently, and therefore the H column remains vacant for the whole of the competencies in the psychiatry section. So this is where we stand right now. Again, the question comes, when can they be interested to take a detailed history or even to do a independent mental status examination. So this is a group from University of Bern, Switzerland, which has been doing some work, I guess, because most of the literature in this shows up their articles. So this is a systematic review of entrustable professional activities in psychiatry. So this is not restricted to undergraduate or postgraduate, but then includes both. These conclusions which this article comes out with. One is that the concept of EPA based curricula seems to be becoming increasingly present. Yes, it is increasingly it's become more aware. We have become more aware of it now. a focus in the specialty of psychiatry, both in undergraduate and postgraduate. So not only to post-graduation, but it is also relevant to undergraduation is what this review says. But then the lack of empirical research in this context is an important limitation for education practice recommendation. Therefore, there are no practice recommendations as of now. Currently, there is only preliminary but promising data available for using EPAs with regard to educational outcomes. So what's important is preliminary but promising. Entrustable professional activities seem to be effectively used from a curriculum design perspective. So seem to be effectively used for both UG curriculum and PG curriculum in psychiatry, but then there are no practice recommendations as of now. Now, coming to the specific area of use of EPAs in undergraduate medical education. So this is not only restricted to psychiatry, but overall. So this is, and again, the same group of people who are working in this area. So what they say is that different approaches that have been developed for postgraduate EPA-based curricula could be similarly used for undergraduate clinical rotations. So, the way how Dr. Kaushik has been, forming this particular, approaches and development of EPA-based assessments. So similar sort of things can be used for undergraduate clinical rotations, but then how that it has to be little, modified. What they suggest is that there has to be 3 stakeholder perspectives when developing EPA-based curriculum for clinical rotation. One is identifying that there are some things which are not specialty specific, but for every specialty. So overarching undergraduate curriculum based core EPAs, which can be for a lot of other specialties. For example, say empathy, AdCom module. These things are common for every specialty. Then specialty specific clinical contexts at undergraduate level, identify them, and identify what are the specialty specific clinical contexts which are important for post-graduation level. So these are the 3 stakeholder perspectives that need to be delineated, is what this paper says. Like Dr. Kaushik's paper, they have been doing wonderful work in this area in India and trying to come up with a model where they're trying to develop this particular aspect of entrustable professional activities and in postgraduate psychiatry assessment. But then what we have to know is that similar sort of frameworks can be implemented onto undergraduate psychiatry training too. But when I personally always believe that even this curriculum, it doesn't tell us what we will be doing when interns come to our department as rotation. So in psychiatry, so are the competencies what we are seeing during the semester postings, are they the same, or what are we going to do with them in the internship? So this is an explorative study again from the same group from Switzerland. They have kind of created something called as nested psychiatric clerkship entrusted professional activities, which are similar to what other entrusted professional activities are. Like say, take a patient's personal psychiatric history, mental status examination, prioritize differential diagnosis, interpreting tests, initiating involuntary treatments, recognizing and treating psychiatric emergencies, developing a management plan, presenting a clinical encounter, identifying, reporting opportunities to improve patient safety in psychiatric hospitals. So they have identified these 9 entrusted professional activities as nested psychiatric clerkship, and to be specifically assessed and implemented during clerkship. Clerkship is internship. So what they have found out after that such training or after that internship is that there are some entrustable professional activities that improve greater compared to others. So taking a patient psychiatric history and assessing mental status improves tremendously. There's an average change of 3.4. Now, this is a Likert scale, which is 1 to 6. 1 is only observation. They can be done only on observation. 6 is indirect observation. So they need not do it under observation, completely independent, but indirect supervision. So somewhere from 2, they moved to 5.5, almost near independent. So this is with respect to taking patient's history, assessing mental status, and also presenting a clinical encounter with a psychiatric patient. So, presenting a case. So in these aspects, they found out that they improve significantly. So what I can, get out of this is that once they finish their internship and a resident joins, so he is already at a different level wherein the training can start. Different other interested professional activities can be entrusted upon him, and so obviously we will have a window of time where we can teach them more, so that they can acquire more knowledge in different other aspects of psychiatry. And this is the Association of American Medical Colleges, which again has come up with core entrustable professional activities for entering residency. So before entering residency, they need to be having these 13 entrustable professional activities, trained on these. So the same 10 which are already there. Along with that, there is something called there is something with regards to writing prescription, and taking informed consents, etc., in this. So in all these, each of these 13 entrusted professional activities, there is this schema which they have prepared. So you can see here that initially, what level they are. So these are the behaviors requiring corrective response. They may not be able to collect accurate history. They may be disrespectful in interactions with patients. They may fail to recognize patient central problem, and then slowly they develop behaviors across, the training during undergraduation, before entering residency. So they start gathering more and more data, and finally reach a stage where expected behaviors for an interested learner are obtained. So, he is able to obtain complete accurate history, adapts communication skills to individual patients' needs and characteristics, demonstrates astute clinical reasoning, performs an accurate examination in which is logical and fluid in sequence. So slowly across different rotations before entering residency, including the internship. So we will have to track them on these behaviors and slowly teach them how it should be done. So, Association of American Medical Colleges expects, a person before joining residency to be having these 13 interested professional activities, and again, I believe that, when you say professional activity, it's not just clinical or academic only presenting cases, but I always feel that, undergraduate, research is very important. So there may be some research-based competencies also put in, in the undergraduation. I have few of my students who are already, I have put them into some research activities under me, and then again, there can be interested professional activities specified for undergraduate research too. Dr. Vikas from Cbme and the group, they have been doing a lot of research on this, academic research on academic psychiatry. They have put up papers where they have described challenges with the current curriculum and how we need to be facing them. So in the end, I would like to say that Dr. Kaushik is doing a commendable job, and few other centers too. But then it's just a start. So they have started this for post-graduation. This phase to go up to undergraduate psychiatry, again, I think it will take some time. So, this is, for the next decade, this is a research agenda that, most of us can take up. And, wherein we, at the end of the decade, maybe we come up with curriculum, which is, where these interested professional activities and interested decision-making, becomes a core element where, the residents or the undergraduate students lead up to a particular level where they are able to give proper patient care. Thank you so much.
Thank you, Dr. Sai. It's a very good presentation, and after understanding the amount of evidences which is you have presented, so hope as Dr. Kaushik is doing lots of research, it's an area where we should be gathering more information and more evidences as per the Indian context, undergraduate and postgraduate. So there are some comment in the comment box. I think first we, give the opportunity to the students so that we can discuss in the last. So first we can, invite Dr. Ankit Dangi. He is a senior resident from Department of Psychiatry, AFMC Pune. So Dr. Ankit Dangi, you can start. You have 5 minutes.
So thank you so much, sir. Good morning. Warm greetings to all the esteemed faculty present and all my colleagues. So it's actually, I feel fortunate that I'm a part of this discussion, which seems so appropriate and apt at this point of time as we proceed into, newer avenues into postgraduate medical teaching. As Kaushik sir has already brought out that we have done some research, some implementation has already taken place in our center. I was in final year when actually this project started, and we started working on first the Cbme and then finally coming over to development of EPAs for psychiatry. Now I am working as a senior resident here, and now on the other side of, when I'm involved more with teaching learning of students, I realize that there could have been certain things which would have been done in a better manner, and I find that EPAs is probably or possibly the solution for future for these things. A lot of things, assessment was already a part of our training in psychiatry at AFMC. So we were rated for our case presentations, journal club, seminar at a regular basis. That thing was done. One thing which was not consistent or which was probably lacking was that the assessment of our performance in the wards, in the OPDs, though it was done, but it was not structured, it was not formalized. So we were given feedbacks, but again, that feedback was not, it didn't have it, it didn't have a structure to it. And most of the times, the recommendations were not very clear cut as to what and where we can improve. So when I now look at that, our first years have come here, how better we can do it is that the assessment has to be in the workplace. It has to be consistent, and it has to be done in a formalized manner. They have to be given clear-cut instructions, outcome goals which they can achieve. They should be broken down into small pieces, small achievable targets that should be done. Something of that has been started, like in our wards and OPDs, when case presentations by residents, which are done on a regular basis. So they are given, one thing is identified from their presentation, wherein which we feel that they are lacking. Say, for example, a resident has to talk about the investigations which are required to be done for a patient. So he has to come to a conclusion as to which investigations would he like to rule in the diagnosis, investigations to rule out the differentials, and investigations which he would like to be done, which will help him in following up the patient. So this is one part which we have broken down it into one part of an overall EPA, wherein he has to assess and present a patient. So he is given something which he can achieve, something which is which has a clear-cut target for him to work on till the time he has got his next presentation. So like e-portfolios sir has talked about, so with those e-portfolios, the resident comes to the concerned supervisor or faculty on a regular basis, shows them what he has worked on, and he can be assessed subsequently on whether he has gained that one competency or not, and whether he is ready to move or be promoted to the next level of EPA that is required. So that is where we are currently, and that is where I, as a senior resident, having done my residency, and this is probably, I think, a wish list which can be done. So with this rest, I think already has been talked about by Dr. Sai Krishna very appropriately, and Kaushik sir has already talked about these things. So I don't think on a technical aspect I can add anything more than that. But this is something which appears to be that can be done, and which can have good outcomes for both the residents in training and our clientele. So thank you so much, sir.
Thank you, Dr. Ankit, and it's a wonderful that your undergraduate and then now senior residency your post-graduation is happens in a way and you were involved in the research. And senior residency is the one area which, somehow not very structured, and it's good that you have been, involved in teaching learning exercises, and that's where the, foundation of good teachers can be put in. So thank you, Dr. Ankit Dangi. Now we will move to another Ankit Reddy. He's a MBBS student from AIIMS Bibigiri. So Ankit, please start. You can share your experience.
Good afternoon, everyone. I'm Ankit. I'd firstly like to thank the organizers and Dr. Ajay sir and Sai Krishna sir for giving me this opportunity. I would keep my discussion very limited and restricted because most of what I have to say has been covered by the previous more experienced and learned speakers. So I probably am the youngest and inexperienced one. So I'd like to apologize in advance if I say anything which is wrong or contradictory. So I think EPS have often been defined for postgraduate medical education or for resident training and seldom for the undergraduate training. And as Sai Krishna sir has just pointed out, I think we have to draw parallels at some level. And even though by scaling things down, we should be able to adopt some of the same for the undergraduate training. And the current CBME that is followed for us undergraduates, it probably does not fully capture or like focus on the actual performance outcome. And the argument in favor of this is that these competencies have been defined in parts or as individual domains, and when they bundle up or they do not add up as a whole for the practice of medicine or for any specialty. So as Sai Krishna was saying, maybe even though not for a niche specialty, but we can draw these parallels for on a broad basis and in general for the practice of medicine. And as it has already been said by Kaushik sir, that these EPAs are basically a synthesis of like multiple competency domains, be it knowledge, the skills, the attitude, or carrying out the task in itself. So the traditional or the conventional competency frameworks that we have, they focus more on the qualities of the person, whereas the EPA, I think, would focus on the quality of the work that has to be assigned or that has to be completed. And that would ground the outcomes in the tasks of physicians about physicians with an approach to the Cbme that it would better address the concerns around integration of all of these competencies. And as it has been said, that it would help in the integration of various competencies that we are required to attain in due course of time and facilitate carrying out a specific task in a more efficient manner, and would also aid in holistic development of a student right from their undergraduate days onwards. So psychiatry as such, what I feel or what I've noticed and read is that it is often neglected, and it has been pointed out in the chat box just now as well, in the undergraduate curriculum for how little weightage it has. I mean, it roughly has about 6 to 12 marks in the curriculum that we follow at AIIMS Univers, and it is strictly being looked at from a marks point of view across the country as well. So maybe the introduction of these EPS from an early point would provide a major push in this regard, and would also sensitize our students in viewing the subject more than just a compulsion. And a previous session that I had seen on this forum on the YouTube channel dealt with upscaling psychiatry teaching, and the undergraduate student perspective that was presented or that was put forth was to make psychiatry a separate subject with a separate exam. And in fact, just yesterday, I was talking to Sai Krishna sir about the same. And he said that in the circles, in the professional circles of psychiatry, this has often been discussed, but the undergraduate response could not be gauged. So maybe a separate exam would only result in students finding ways and means to circumvent the hurdle, because time and again, so some MCQ book or some sort of a guide will come up where people will speak about only reading certain topics, even if you give it more weightage, say give it 20, 25 marks or something of that sort. So they would always find ways and means to just bypass that exam. And like a mere reading of psychiatry as a subject may or may not enhance our knowledge of it, and it may or may not change the attitude towards it, towards the field as such. But maybe having a more inclusive and intensive training rounds or rotations with like a process oriented or application oriented approach by means of carrying out an EPA, which could be as simple as having a small group discussion or as Sai Krishna sir said, eliciting a comprehensive history or doing some parts of the mental status examination, whichever is relevant to an undergraduate in that particular 6th or 7th semester. Maybe that would help in developing a well-rounded approach and shape our learning curve and trajectory in MBBS in a better way. But what I've read online is that, however, if these entrustment decisions, they do not lead to increased autonomy in going forward in our practice, but and if they're only serving like tick boxes on a paper, then we will anyway be seeing it as again a competency that we only need to achieve or we only need to collect in order to pass. And as sir pointed out, that in that column H there was no marking that this needs to be there for certification or graduation. So maybe we need to work towards these EPS not losing their original meaning of units of practice for which one becomes qualified. That's it from my side. Thank you.
Thank you, Dr. Ankit. And it's a very true and truthful presentation, basically. And every undergraduate actually feel and goes through the same feeling. Other thing is that we have overwhelming response in the chat box, and most of the comments are there. And few comments I would like to read if I'll see that whether it can be answered. One comment from KK Mishra, they said that the logbook, basically what he's telling that the logbook is not a very, suitable tools to, use. Logbook are never taken seriously. That is very true. And here I think Dr. Kaushik can share, because he has mentioned the e-logbook portfolio and the paper logbook. What your experience about logbook, sir?
I had started off with the same point of view that, logbooks are merely things which the inspecting, when the MCI inspection or the local university committee comes, it is relevant at that time. But then over the years, I have changed my view completely. I think it depends on the institution, its ethos, and the faculty, how seriously they take the logbook, how they demonstrate to the resident that this logbook is actually not just a record of what they have done, but also a record of their growth and improvement. And we use that to give feedback. And I'll tell you what a few things that we have learned along the way. For example, up to now, our logbooks have been recording journal clubs attended and journal clubs presented together. Now, from now on, what we are doing is we are separating the two, because there is very much more ownership in the one that you have presented yourself, right? And I've already shown you how we have our trendograms, which shows, it shows to a person that in your first year, you were possibly not doing so well in your presentations, and look how you improved. So logbooks, I have come around to the point of view, both hard copy and e-logbooks are useful. How useful they are will be determined by the milieu or the importance that we give it. Three things I find will add to this. One is, if you give the marks, the quantitative part, you do it immediately and have the person record it. Okay, if it is immediate. If it is expected that if you have the senior resident reviewing the logbook every month, and if you have the guide reviewing the logbook every quarter, just watch how much more important it will become, and it's not filled in the last moment. And the third thing is, when it is expected to contribute, that जब भी कोई resident मेरे पास logbook लेके आएगा, I will give feedback. So then they are coming not for the logbook, but they are coming for the feedback. So I have totally veered round to the point now where I believe that logbooks are not just useful, they can be very useful. Now, there is problems in designing e-logbooks. We are still grappling with that, but the way forward may be e-portfolios more than logbooks. So that we haven't got there. I don't have personal experience with that, but what I gather is the advantages are there, which are many. That means if you put your e-signature in the ICU when you're attending a call with a resident, you have evaluated then and there. There is no recall bias. So that is one of the things. Yes, I would. That's what I have to say.
Thank you, sir. Although there's other comments, but time is a bit less. I just try to, was reading those comments, and most of them are basically from undergraduates, and it's a very good thing that lots of people wish to interact with the faculties, and some of as the Dr. Bhavesh suggested that the psychiatry should be included in the undergraduate exam. It's a very long discussion is happening quite a lot, quite a time now. So that is there. Then there are other suggestions.
The way I think we can achieve that, if you permit me, is if all of us as psychiatrists interact with the vice chancellors of the health universities and tell them that the commonest cause of death in the 15 to 39 age group is suicide. And we tell them that if we don't treat if our doctors don't have the skills to deal with this, this will become a huge bugbear, and that which is measured improves. So we have to not only train our doctors with the skills, but also have it as an exam for all doctors passing out or in the MBBS. This is one strategy I can suggest in this regard.
Thank you, sir. So, and further, there is some suggestions from Dr. Kishore that we may, recommend and try 5 EPAs for undergraduates.
Very good.
Okay,
Yeah.
and there is a suggestion from Minds United, which is, a platform that the number of faculty and student ratios can be increased. That is one way, increasing the, better assessment and, decreasing the bias.
Absolutely.
So all that is there. In the last, I will hand it over the mic to the, Dr. Kiran, so that he can, wind up the session. And if there is a, usually the Dr. Mohan's Isaac will be there, but today I am not able to see him.
No, sir is there. Sir is there. Mohan Isaac sir is there.
Please,
Sir,
please.
So we request a couple of comments from you, sir. Dr. Mohan Isaac sir.
Yes, sir. Please, sir. Please, sir. Dr. Mohan, sir.
Ajay, thank you very much. I never miss this program whenever I can, except when I am traveling and I have no access to, internet or computer or a mobile. Otherwise, I think Kiran would know, because he is the primary, mover of this program. I have attended most of the program. So yes. I've been there right from the beginning, Ajay. I, of course, did not put on my video. I just want to, you have already mentioned about the time, we have exceeded the time. I just wanted to make 2 or 3 comments. It's been an excellent program, excellent presentation on a topic which is not very well known to a lot of people. I mean, these are new things. I mean, see, in the more advanced countries, competency-based medical education, postgraduate education, etc., came up at least a decade ago, at least from the 2010, 12, etc. And Dr. Tikka referred to the Canadian work, and Canada has been, the Royal Colleges of Canada has been, in a way, moving the whole agenda of improvising medical education all over the world. In Australia, of course, the EPA guidebook was, the AIIMS Cbme published it in 2012 or 13. But in our country, this is new because a competency-based education has come only more recently. And a lot of people are not fully aware of all these things. So my comments are as follows. Number 1, compliments to the Department of Psychiatry at AFMC for not only doing work on this very meticulously, but publishing it for the benefit of other people. Honestly, I was myself not aware of these papers. I have not read through it. I will be going through it, although Dr. Chatterjee has given a little gist of the paper. That is indeed very good. I don't think many other departments have been doing work. Of course, they're working on medical education, postgraduate education, psychiatry, etc. But this kind of meticulous work and publishing on EPA, I don't think anybody else is doing. Second point, I think the issues have been highlighted by the first two speakers, and of course, the younger colleagues who are postgraduate students have contributed to that. The issues are when we introduce this kind of a, more modern method in our country, there are numerous issues. For example, let me quote what Dr. Chatterjee said. That you need multiple assessments by different supervisors and different methods. Now, most of our departments have forget about multiple supervisors. They have limitation of supervisors. In fact, I think the Indian teachers of psychiatry, this whole platform, this Sunday with psychiatry teachers, Sunday special 60 minutes, all these were introduced to enhance the quality of training and etc. etc. So we have a lot of constraints. In fact, suddenly the postgraduate centers have increased in our country. And I must say just about a dozen or maybe a dozen and a half. Of course, AFMC included, St. John's, maybe JSS where Kishore is there. Besides, of course, All India Institute of Medical Sciences, New Delhi and all that. We don't have enough faculty. And that takes me to the second point. And that is again what I'm quoting Dr. Chatterjee, who said that you require blood, sweat, toil, and tears. Now, how many teachers, psychiatry teachers in our country are willing to or can confidently say, I am willing to give my blood, sweat, toil, and tears for improving psychiatric education in the country? I'm afraid not many. Of course, the 30 or 40 people who are attending this are not in that category. But, Kishore has calculated how many teachers are there in psychiatry, undergraduate, postgraduate. And as I mentioned earlier, I have attended most of these programs. I don't worry about the numbers, but it's usually the best of 50, 60, etc. So to find teachers who are willing to give blood, sweat, toil, and tears is a difficulty. Now, the third point is, even internationally from developing countries, when you look at the published literature, you find that most of the papers are on, the development of EPA and the implementation, the practical, very much like what Dr. Chatterjee mentioned. How they developed it, how they implemented it, what were the programs, problems, the challenges, how they wrote the first paper, and then they realized that there's lots of things are not really relevant. Then they put. So what is lacking, even internationally, where they have a lot more experience, is again, as Chatterjee pointed out, evaluation of the impact. It's all good to say this is a new method, this is fine, but is there robust evidence that this is better? At least in one area, I know. The method of examination in Australia, people are talking about OSCE. Is that the best way to examine our postgraduates and undergraduates? People are now re-looking at the old method, which was maybe valid but not very reliable. We improved lots of things on assessment to improve inter-rater reliability, but in the process, we may have lost validity. So coming back to this EPA, I think there should be studies also of the impact. Now, we in India are all far away, from that, because we are in the process of developing it and implementing it. Now, I just want to, I enjoyed all the four talks. They were of a very high standard, particularly the first two talks. The students, of course, they pitched in, what they know and their contributions. Now, one last comment about the logbook, because we had a little discussion on that. And Dr. Chatterjee again has given his definitive opinion. I must tell you that although Dr. Mishra made a comment that it is just a formality, nobody looks into that. But I think things are changing. It may have been like that. In the olden days, when I did my post-graduation, and that is already 40 years ago or so, there was no logbook. I mean, if your boss is happy with your work, that is it. You come on time, you present cases. I mean, things have changed over the years. Now, I must also tell you that my son is a sailor. He's a mariner. And he tells me about logbook. In fact, the history of logbook is that it has come from the 1500, 1600. Even the log is a wooden log. The initial purpose of the logbook was to know the speed and the position of ships. Those days we didn't have the GPS and the Google Maps and all that. I would agree with Dr. Chatterjee that it is very helpful. We teachers have to make it useful. If the teacher pays importance to it, then the students will pay attention. And now we also heard about the electronic logbook, which is, of course, everything is electronic these days. It makes things much better. But I think Dr. Chatterjee made a very useful point. While e-things are okay, there should be a hard copy also. I think that is a very important thing. I mean, I just came back from the USA. When you go to USA from Australia, you have to have an electronic. It is called ESTA. It's a kind of an electronic travel authority for people who live in Australia to go. You don't have to get another. But then they insist that you must also carry a paper thing with you, because if the officer wants to have a look at it, then you should do. So logbook also, while the electronic logbook is important, I would imagine the paper book is also important. That is all. Back to you, Kiran.
Thank you, sir. Thank you for those valuable comments. I think we were overshooted, and one of the principles is on a Sunday morning is to keep it back to 60 minutes. So with this, I think we'll wind up the program, but it was a wonderful session. I would like to thank all the speakers, Dr. Kaushik Chatterjee, Dr. Krishna Tikka, and both Ankith, Dr. Ankit Reddy and Dr. Ankit Dangi, and also Dr. Ajay Kumar for the moderation. I would like to thank the attendees who have attended this program. There are a lot of pioneers in medical education. We have Dr. Vikas, we have Dr. Kishore, Dr. Vinay, Dr. KK Mishra, Dr. Bhavesh. We have a lot of them. And thank you for pitching in and making this program a huge success. As promised, the whole program will be available on the ITOPS website for any future references. And hopefully we will come back and we'll revisit this EPS in the near future. Thank you very much and have a nice Sunday.
Thank you.